Northern Queensland Primary Health Network acknowledges the traditional custodians of the lands and the seas on which we live and work, and pay our respects to elders past and present. Firstly, introduce Jen. Jen's got a range of experience, 20 years experience as a nurse, Army, Royal Flying Doctors, the hospital sector, primary healthcare, and she's been in general practice now for the last 10 years. Firstly as a nurse and now as a practice manager. She's got a Master of Nursing in Primary Healthcare and a Diploma in Practice Management. Jennifer enjoys sharing her knowledge through teaching and mentoring both nurses and admin staff, and enjoys the challenges of general practice and her role as practice manager. Thanks, Jen. I'll let you take it away from here.
All right. So, yep, challenging. I do love the challenge, although this year sometimes it's been a little bit challenging. So I'm sure you can all relate to that. In fact, the night before I came up here, I just was scrolling through Facebook and I came across an article from ABC News, and it was particularly mentioning Townsville, Mackay, and aggressive patients happening. So the GP in Moranbah, who was assaulted by a patient, punched twice and pushed to the ground. The patient didn't get the vaccination exemption certificate. So you can see like people's anxiety in the population is really high. And so that's, there's already a trigger before they walk through the door. Practice in Mackay, who's, making sure her staff don't leave alone anymore. For a lot of practices, they're increasing, like security has become a big issue for most practices. My practice, we're currently doing a fit out, and in our new practice, we're going to be having direct alarm, CCTV, the works. And we don't even live in the demographics of our patients is pretty good in that respect, but it's just such a risk. And, as an employer, you just, you've got an obligation to make sure your staff are safe. And I think different to, say, the hospital sector where they've got security on tap, we don't have that luxury. And so, in fact, we actually get a little bit more of that aggression than sometimes the hospitals do. So it's really nice to be back in Townsville. My first time in Townsville was when I was in the Army, and I was lucky enough to live on Palm Island for 5 months in a tent on a beach with an engineering unit, and I got to spend 5 months going around with the Aboriginal workers and vaccinating all the kids on that island. And I took a whole group of women over from a remote island for a health retreat, and unfortunately I broke my arm on the way back, so that was the end of that. But really fond memories of Palm Island prior to other things that have happened there. I have 2 kids in the Army now, and they recently lived in Townsville. So 2 years ago I had Christmas up here, and my granddaughter was born up here. So and I love walking up. Is it Castle Hill? I'm making that my task every morning to walk up the goat track. So yeah, it's nice to be back. We're just going to get an idea of who we've got in the audience tonight. That's okay. A good range of obviously a lot of admin staff here tonight. No nurses. All right, so we might just move on then. So the first half of tonight is listening to me, and we're going to identify aggressive and challenging behaviours, and I'm sure you already know how to identify them, and figures that can trigger them. We're going to look at how to manage these using effective communication skills, and we're going to look at strategies to ensure a safe environment for your staff, your patients, and anyone else in your practice. And I'm sure this is a lot of stuff that you probably already know. And for me, when I was putting the presentation together, I was saying to Nicole last night, it actually just reaffirmed to me that I'm actually doing the right thing, because a lot of it I just learned on the job or maybe learned from each other. But it's always good to have a refresher, because I think sometimes we get complacent and we get tired, and so sometimes it's good to just reset. But we're going to start with a little activity. We're going to start with a little deep breathing exercise. So I want you to make sure you're comfortable in your chair, or uncomfortable wherever you're sitting. Make sure your back's supported, your arms are supported, your legs are sort of supported on the floor, and place your hand just below your ribcage. And if you feel comfortable, I want you to close your eyes. Now I want you to take in a very slow, deep breath, so you're giving right into your abdomen, and you should feel your hand rise rather than your chest. And when you've taken your big, deep breath in, I just want you to pause at the top slightly, and then slowly exhale. And as you exhale, I want you to just imagine all the tension from today's work and everything that else is going on in life, just release and drain from your body. And we're going to just do that about 5 times, inhaling to the count of 4, and then exhaling. I'm going to let you do that. And as you exhale each time, just try and just release all that stress and tension from today. And one of the things that this does is this helps to calm down your nervous system. And it's a really good strategy when you're in a moment where you've got a confrontational situation to calm yourself down, and which I'll talk a little bit about later on. But I just wanted to start just to get everyone relaxed. So when you're ready, you can open your eyes and we'll get into it. So you need kind of cushions or like beanbags, really, don't you? Okay. So what do we mean by aggressive behaviour? So there's lots of different definitions of aggression out here. This is one from the RSCGP, and it basically says that patient aggression and violence, because it is a spectrum of behaviour, are defined as incidences where team members, contractors, and anyone else in the practice are abused, threatened, assaulted in circumstances related to their work, and they can be explicit or implicit challenges to your safety, well-being in the team. So I'm sure you'll agree that things that include aggression and violence, like threatening emails and letters, and I'm sure a lot of you have known this here, threatening phone calls, people yelling, screaming, being rude over the phone. But it also includes things like forced confinement, assault, as we just mentioned before, and sexual assault, and even stalking. So there's a whole range of behaviours. So challenging behaviour, and this one took me a little bit to get my head around because I'm like, really, what is the difference? Challenging behaviour is anything that you as an individual find challenging. And I thought, how can I explain this to everybody? So when I thought about it, I thought, remember when I first started in general practice, but really when I first started on reception, because reception is such a challenging job. I found a lot of conversations and dealing with people's requests really challenging. But with time and experience, and when I got to know protocols and, listened and learned from other people and colleagues around me, with time I found those situations less challenging. So they can challenging can be just something that you find challenging. But the thing is, the principles of how you manage those situations is no different, whether it's challenging or just a little bit, an anxious or agitated person. And then it changes a little bit as the patient becomes more aggressive and violent. So I thought, let's have a look at what the incidence of violence and aggression is. So there's been a lot of, I don't know if you've got on social media, but I'm on a few forums and a lot of Australian doctor articles and things coming through this year that are acknowledging how challenging general practice has been in the past 12 to 18 months. And particularly there's been a lot of acknowledgement of what receptionists and how they've been really under the pump this year with every code update, every government announcement that's announced before we even know about it. I sure agree, and my phones just go crazy as soon as something's announced on the radio, and we haven't even managed to set up clinics or anything. So on average, it's really interesting because when I go back 10 years, so the second article is from 10 years ago, the statistics really haven't changed much. So they say most GPs in any 12-month period, from about 57 to 64%, will experience some type of aggressive behaviour from patients, most commonly verbal and often occurring daily. And sometimes I think we do think at the front end receptions do get it more, but you've got to think about the GPs and having to say no to scripts, no to certificates. They have to. A lot of the time they do have to say no to someone and start taking something to get what they want to win into that consult for. But I think GPs also get all the good training along the way, whereas we don't. So it's really good that we're having these kind of sort of meetings and training, and I know there's been a few webinars on this topic this year. So another Australian study in 2009 found that receptionists was just as likely to encounter patient-initiated aggression, and that because receptionists are the gatekeepers, they do tend to get a lot of it, and a lot of that low verbal violence. So there's different types of patient-initiated aggression, and so this just breaks them down into categories. So again, you can see that verbal and written aggression is the highest. And I think people behind phone, they're sort of, it's easy to be aggressive to someone when you're, not in front of someone or just on the phone. So GPs, again, tend to experience high levels, but then I don't really think there's been a lot of studies specifically looking at reception staff in general practice, so it would be an interesting thing to do. Property theft and damage, sexual harassment, physical assault and stalking. So we're just going to do another little poll now because I thought it would be really interesting to find out what types of patient-initiated aggression that the person experienced in the current role, in the last 12 months. So if you want to go back to the menti.com, you can pick more than one option and just maybe want to indicate, I mean, it's all anonymous, if you've experienced any of those types of aggression. Yeah, so pretty similar to last night, verbal or written aggression, the most common, and a little bit sad to see sexual assault and physical assault, but there's certainly some work to be done. So there are some risk factors for practices in terms of the likelihood of patient-initiated aggression. Staff and health can influence the likelihood of it. So female GPs, and particularly younger female GPs, tend to experience a lot and often fear and change the ways they work as a result of it. Younger GPs, registrars, and younger GPs in general, and as they get more experience, they tend to get less. And I think that's just like us, as I've got longer, I've been working longer in general practice and learned to deal with those challenging behaviours. I don't think to, pick on the maybe it's just a wrinkle from graduates. International graduates. So one of the studies suggested that perhaps due to cultural and language issues, but I'm sure there is an element in there as well. I've got two, the most Aussie GPs who've ever come across, born, bred in Australia. One's Dr. Jane Chan, Asian as they come, and my practice is in a very conservative, high area, and so it took a long time to start with patient base. As soon as people see an Asian name or an Asian looking face or an Indian doctor, and he's that's one of my best. Great following now, but certainly, we've got high one in Australia, which is pretty sad. Time of the day, so certainly at the end of the day, am I not loud? Oh, sorry, can you hear me now? So at the end of the day, and certainly doctors staying back. I have a few doctors that stay back after hours and working alone, so that is certainly a risk factor. Geographic location, I've read a few different things. Some say regional, rural, high risk, and some say urban, but I think probably it's more the patient demographic. So low socioeconomic areas, high rate of unemployment, poverty, drug and alcohol, are certainly going to increase the risk factors for things like this. And practice size. So the larger your practice, apparently the higher risk you are, and that's probably, due to the fact that you have a larger patient population in general. Run it. Go narrow. Okay, so the impact of patient-initiated aggression on. So I'm sure you can, as you can see, these are some of the impacts on the screen, but I'm sure you'll all agree that it can have some pretty devastating impacts on the individual and the whole team. And so, it can affect someone's personal life, working life, social life. It can also have a cumulative effect. So the more exposure and the more times you're exposed to sort of patient-initiated aggression, the worse it can become for us. And so sometimes you might even find yourself with your colleague overreacting to a situation that may not have been as kind of aggressive as you think. And I know there are times like, and I think it's really good to be able to say to someone, I don't feel up to the end of this patient today. I don't have anything. Do you mind taking it? And that's good teamwork. We do that at work all the time. And I do it, my team do it. I'm like, I just can't manage this patient today. So I think it's really important to acknowledge when you're feeling like that and knowing when you need to have a break. I say to my staff, if they've had a difficult encounter, I've had two staff this year, younger staff, same patient, make them absolutely, burst into tears and when that happens, I'd rather you go take a break, go for a walk around the block, rather than just take the next phone call, because you need time to come down from those emotions. And it's not fair to the next patient. So, of course, all these kind of things are ultimately going to influence whether someone stays working in the environment. In current workforce, shortages and compulsory vaccination is really important. And, it takes a long time to get everything up. So, we really want to hold on to those stuff. Make sure they're feeling well supported. So,
Can I ask a question?
Yes.
Sorry. So what do you do when you have a patient who is abusive to a staff member that reduces them to tears?
Yeah.
How do you show support to that staff member, apart from saying go reset yourself?
Yeah.
to, you send a letter to that patient, you say,
Yeah, we're going to talk about that a little bit longer on, but so I did have a particular patient this year, and I certainly had a conversation with him over the phone to the point where he was yelling at me, and I was like, you know, you are yelling at me, and I really want to talk this through with you, but I need you to, you know, lower your voice. Oh my God, Kelly, I just got a loud voice. And I'm like, well, a lot about communication is perception, and my perception right now is that you're yelling at me. So, yeah, and then finally it sort of de-escalated, and he did then, and then I followed up with a warning letter. And I've got the full support of my practice and all of that kind of stuff. I have them ready-made in my practice software so that I can please do them and then customize that patient. Yeah, and it definitely sets the boundaries then, and particularly if I they really love that software and love things that are at the table. So there are a whole range of things that can trigger aggressive or challenging behaviour. As you can see, I think there's some pretty common themes there. Certainly a lot of those I can relate to. Even as a patient, I can relate to some of those as well. So we're just going to have a look at the phases of the aggression cycle, and the reason to do this is because we don't start off angry, we don't start off aggressive. Most of the time, most of us are calm. But so, for example, we take a common example. I'm calm, I've got a doctor's appointment, I walk in, I check in with you, and I sit down to wait for my doctor. I'm pretty calm at this stage. Then the patient in the GP before me is taking a lot longer, and it's kind of eating into my patient time now. So I'm starting to get a little bit, you know, anxious about that. On top of that, I'm actually at the doctor's surgery because I've been recalled for some results, so that could make me a little bit anxious as well. And on top of that, I need to race back to work after this. So there's a couple of things that could be triggering me there, or it could be a combination of all of those. And so the trigger causes an emotional response. Usually it's something that causes frustration, embarrassment, or something like that. And as a secondary emotional response, you get angry. And when you get angry, you get anxious. And so the anxiety is sort of simmering away there. So if the situation's left and isn't dealt with, it escalates. So I'm sitting there waiting. Maybe the waiting room's a little bit hot, the chairs are uncomfortable, my anxiety is starting to sort of get worse. I might be even getting a little bit agitated now. So I come up to the desk a couple of times now. I'm like, do you know how much longer it's going to be? Nothing worse than not knowing, hey, sitting in the waiting room. So my anxiety's mounting. Now I'm starting to get a little bit flushed in the face. But I've released a little bit of adrenaline and you know, I'm getting that fight-flight response. So I'm starting to get a bit fidgety. I might start pacing or tapping my foot. My tone, each time I come up to you, my tone of voice might be getting a little bit sharp, and maybe my language is even changing. I was really polite when I first came in here, but now I'm just getting a little bit cranky. So if we leave that situation, it's going to keep escalating. But if we can sort of stop it early in this escalation phase, you know, it's easier to de-escalate someone when they're just a bit anxious or agitated than when they're aggressive. And so, you know, I really encourage my staff to go up to someone, get up behind reception, go and say, look, I'm really sorry, the doctor is still running behind. Can I get you a tea or coffee or a glass of water? Every time I've done that, that patient's like, oh my God, thank you. Like, that just doesn't happen in general practice, right? Might happen in specialist rooms, you know. Oh yeah, no, I totally understand. I'm like, no, I don't know how much longer, but you know, those little acts of kindness can really make a difference. And there's nothing worse than sitting in a doctor's room and just not being informed. So again, I know reception is really hard. There's phones ringing. They've got all this stuff going. Good, you know, but part of their job is to monitor that waiting room. And if they understand the signs of someone who's got anxiety or agitation or is increasing in that, they can possibly intervene. So in my new clinic, we're really fortunate. We're actually going to have a concierge. So we're going to have a concierge who meets and greets people at the beginning, and that's their job, is to wait them. And then the reception going to have, you know, is at the back, and they're people paying and rebooking appointments, so that my reception staff aren't having to multitask 5 million different things, scan things, email things, fax things. So we're just going to separate those roles a bit, and so hopefully that'll help with some of those things. So if we leave it to simmer, someone's eventually going to get to crisis. So by now they are, you know, at the point when they get to crisis, they're at the point where they're not thinking rationally anymore. They are just so angry. So this woman is still waiting. She's, oh, I've got to get to work. She comes up to your counter to ask you again, do you know how much longer it's going to be? But when she gets to the counter, there's two people in front of her and you're on the phone. So she's just got to wait. So by the time she finally gets up to you, she's like, how long is it going to be? And she slams her hand on the desk. So at this point, you can't rationalise with her. The only thing you can do is de-escalate her. Finally, the GP calls her in and we go into recovery phase. So the GP calls her in. We're now starting to talk about our results. She's getting her needs met, right? So some of you could not, that they haven't got their needs met as a trigger. So now she's getting her needs met and her body language, blood pressure is starting to come down. But we really need to be careful here because even though she's calm, and she might be calm when she comes back out to the reception desk, she could easily be re-triggered and re-escalate. So she, for example, she might come back and then there's another two people in front of her and she's still yet to pay. And so you just always got to be careful that, you know, that person is not fully de-escalated yet. And finally, she gets out of there and she might go into a post-crisis phase. And sometimes during this phase, they can go into a bit of a post-crisis depression. And that obviously depends on the trigger, the nature of the event, how long it's lasted. But if someone's been in that crisis phase for a long time, you know, that's a lot of energy is being exerted. They're pretty tired. But often they're also quite embarrassed and shameful because now they're able to think a little bit more clearly again. They're like, oh my God, did I just do that? And we had this lady the other week, she had a bit of a crisis. Her brother was found dead and she wanted a script. So she rings up and she was demanding to put through her doctor now. And my reception staff did everything possible. But then she came in the next day and because she's still really high, her emotions are really high. And so all the expletives came out to my staff. Like, you're a effing, you know, bunch of blah, blah, blah. But then, of course, a week later, she's de-escalated. She's come back and she said, oh, no, I didn't say that to you. I had a phone call and, you know, I said to my staff, you know, even though she kind of wasn't apologising and she was making a bit of a lie about who she was saying that language to, I think she was actually quite embarrassed. Because, you know, it was a week later now, she's like, oh, you know, I understand they were just trying to do their job. And finally, someone becomes stable again. Their body language is back to normal, their blood pressure is back to normal, and they're back to their calm normal self. So as we go through the phases of regression cycle, and as we've just discussed, our emotions also escalate in a very predictable manner. So again, we're calm at the beginning, something triggers and that created that anxiety. And as that anxiety sort of simmered away, it led to, you know, it became more of agitation and then finally aggression. And ultimately, if there's no intervention and it's left, the patient can become violent. Does that all sound pretty reasonable? All right, so I found this and I thought this is a great little acronym to even have at reception, just to remind staff of what the symptoms of someone who is anxious and getting agitated is. And so if we can recognise these signs early and intervene, we might be able to prevent that sort of explosion. So someone who's anxious and agitated and getting that simmering anger under will often stare glaringly at someone, often at the staff. Their tone, as I said, their tone will change. They might become sarcastic, argumentative. Anxiety, you know, is a physiological change. So they'll often become flushed in the face because their blood pressure is increasing. They'll start muttering under their breath or maybe criticising staff or to themselves or others, or even start insulting you. And often they say they might start phasing. I probably think they're probably more just getting a bit fidgety in their seat and tapping their hands, tapping their feet. So stamp, I was thinking about saying like stamp, you just got to stamp it out early, hey. So that's a good little, you can put a laminated little sheet at the front desk and you know, you need to stamp this out. So how do we manage these situations? So I think this is pretty much a risk management strategy. So when you look at risk management, there's always 4 levels. Prevention. So we always want to prevent things from happening where possible. Obviously, if someone's a little bit challenging, we're always going to respond to that in an appropriate way. But if the behaviour is more than challenging and it's aggressive, we need to manage that. We need to know how to manage it in a safe way. And finally, there's going to be occasions when we can't manage it and like we've just suggested with warning letters, we're going to have to set limits and set boundaries with these patients. So policies and procedures. So we all have policies and procedures. Some people go, oh yeah, they're just for accreditation, but they're actually really important because a lot of them are about managing patients' expectations. If you think about it, when you have a patient ring up for the first time, this is when we're very good at managing patient expectations. We say, we're a private billing practice, our standard fees is for a 15-minute appointment, blah, blah, blah. We manage, you can book online, you can book over the phone. So that's all about managing expectations. You do require an appointment for a script, you do require an appointment for a referral. So even though we pay a bit of lip service to policies, it's the way we implement them that's really important. Of course, workplace health and safety policies are important and they are part of legislation. So as I said before, your employers have an obligation to make sure that your workplace is safe. And in terms of workplace health and safety, it's really important that staff also train in those policies as part of induction. Little plug for Practice Hub. I do use Practice Hub, and what I really like about it is it has 8 little modules, online modules that my staff have to do, and one of them includes workplace health and safety. Warning letters. So we discussed warning letters. So warning letters need to be specific about the patient, to the patient. They need to be specific about the behaviour that was unacceptable. I've got a little bit of a bugbear. I don't like it when we send out warning letters without having a discussion with that patient first, because I think it's a little bit rude to receive a letter in the mail that our patient may not actually be aware. They may not have insight. So I do try and either have a face-to-face discussion with them or a phone call first. And I'll often also run it by my MDO, Avant, or whoever you're with. Behaviour contracts, probably only use these twice. Really when it's repeated serial behaviour, but you're still okay to have that patient in the practice. So it does need to be extremely specific about the unacceptable behaviour or behaviours, but it also needs to specify what the consequences are going to be, and usually you get the patient to sign as well. And at the end, there's a couple of RACGP guidelines, and they have actually some great templates of all of these types of letters in them. Avant is another good website. I use Avant website all the time. They have some really good template letters and things that you can amend and adjust. And termination of care letters, I'm sure a few of you have used these. Have you used them? Yeah, I've done a few termination of care letters. Happily transfer your care to another GP. Please let us know who they are. You just got to remember that you're under no obligation to provide that patient ongoing care unless it's in a medical emergency or there's no alternative available. So usually I give the person 2 weeks to find a new GP, depending on how bad their behaviour's been. And of course, this is my zero tolerance policy. So I never used to have it displayed, but it is very recommended that you do have one displayed. If you're going to have one, there's no point having it if it's not displayed, because otherwise no one knows about it. So I now have these on my reception desk. I have it on my PowerPoint in my waiting room. And again, it's just about managing those expectations, right? Say that, you know, this is not going to be tolerated. And I think what it's done for my patients this year is made them realise that this is what we are experiencing. Because a lot of patients, the majority of our patients are great, but then other patients see this sign and they go, really? Do you get that? I'm like, yeah, all the time. Environment. So I think I alluded to this before. There's nothing worse than your doctor running behind. You're sitting in a really hot room with the air conditioning, is it on? Really hot, in an uncomfortable seat. So, like, what is your waiting room like? Are your chairs comfortable? Sometimes there's not much you can do about that, depending on your boss. Is it too cold? Is it too hot? Is there something to entertain them? Most of us have TVs and music to sort of as white noise against front counter conversations, but you know, they've also got to be entertaining for the patients. Safety, so environmental layout. So what is the layout of your practice? My last practice, basically the waiting room was like this room here, and every doctor's consult was off the room, and I would have patients who, I want to see my doctor. I'm like, I'm sorry, the doctor's busy with patients, I can't fit you in today. They would literally sit on the chair outside the door, and as soon as the other patient come in, they'd just barge in. So when I design practices, and I've had the opportunity to design a couple, I'm like, I never have my consult rooms right off the waiting room. I make sure there's a barrier between them. What about reception? Is your reception desk high enough and wide enough to provide some protection? is your reception in a sort of design in a way that patients can just walk in there, or is there a bit of designed in a way to sort of deter them from doing that? So all those kind of things are part of safety. Is anything in your waiting room sort of easily picked up and able to be used as a weapon? Like all these kind of things you've got to think about, right? Like it doesn't happen in all our practices, but if someone's really violent, they're just going to go for something and they're super strong at that point. Exit. So do you have an alternative exit to your main exit? Like if there's only one exit and entry, that's pretty unsafe. And most doctors like to have a back door they can come in, so patients don't see them when they're coming late. I've got one of those. So duress and code systems. You guys all have duress alarms or some kind of code system? No, we haven't up until now, but certainly in the new practice we're putting them in. There are so many options on the market these days. So there's the little green button. Has anyone seen that? That's just one that you press a keyboard, like a key on your keyboard, and it alerts every other screen. Some practices have it where they can just press a button on the phone and it will alert all the other phones. Otherwise, the other suggestion that was mentioned was just having a code system. So just having maybe a short sentence or a word that everyone in the practice knows that I need help. Safety cameras. So I think they're becoming more common. So a lot of practices are starting to put them in their public areas, and they do again act as a bit of deterrent, but are also obviously good if there is an incident and police can then use that footage. And adequate lighting in the car park. So I remember the day when I used to work at the Royal in Brisbane, and unless you wanted to pay a fortune for parking, you park down in dark, dingy netball courts about 2 kilometres away. Pretty scary to walk down there at 11 o'clock at night and there's a few crazies around. So do your staff have access to parking close by? Is that well lit? If they don't, are they walking back to their cars together, or are they walking out of the practice alone? So the particular article I read the other night, that Mackay practice is now sort of mandated that no one leaves the practice alone. So it's always 2 people leave together. So just a little image on the screen. I'm pretty sure there's quite a few general practice here tonight. We only had a couple last night. So this is a typical doctor's consultation room. So anyone suggest maybe what could be changed?
To have the patient so that he can't get out if something happens, like the way his desk is.
Perfect.
Yeah.
So many doctor's consultation rooms are like this, but if the patient becomes really aggressive, there's no way the doctor can get out. So ideally you'd sort of change where that desk is and put the chairs further away from the door. In those RACG guidelines I'm talking about, and they've just released a new one on managing aggression and violence this year. And we've got some really good layouts in the back for different configurations, including like the one we just spoke about. But also one of the suggestions is to have like a alternate door between the consultation rooms, which is not a bad idea if you were redesigning a clinic. Just have a door that you could escape into the next room. I was saying last night to a group, I did a very short stint in some jails in Brisbane. I thought, that'd be interesting. And I used to go in and do this mental health sort of assessments with patients, and they'd go into this like assessment room, and the first thing they teach you is you are between the door and the patient. But it's still pretty scary. I only did it for 6 months. So individual strategies to respond to challenging behaviour. So this is just as much about prevention as managing those challenging, not aggressive, challenging behaviour. So respond promptly. When someone rings up and you say you're going to follow up on something for them, make sure you get back to them in a timely manner. Like even if you say, look, I still don't know, nothing worse than sitting at home going, do they even care? Like, are they just ignoring me? That sort of creates a little bit of anxiety and agitation. Treat the person with respect. The saying goes, treat someone how you'd like to be treated. But part of treating someone with respect is listening to them, listening to their point of view, not necessarily agreeing with it, and acknowledging their point of view and their frustration. We all like to throw around the term active listening. So it's not just hearing, but it's like paraphrasing, reflecting back to the person. So what I hear that you would like is and then they know that you're actually paying attention to them. I guess part of that is also not getting distracted with finishing off that email in front of you and other things, making sure you actually take the time. And, it's really hard at reception when there's a million phones ringing and people in front of you, but sometimes you just got to go in a little zone and make sure you give that person 100% attention for that moment. And sometimes those extra few seconds can really make a difference. and listening to them. People just want to be heard, right? Manage expectations. So we've kind of spoken about this. So making sure that they understand people, we understand what can be done, but people who don't work in healthcare and don't work in general practice, they don't understand our resource or our limitations. They don't understand the legislation. They don't understand that it's not just about bringing up a script and bringing up a referral. It's not just going to be a 2-minute consultation. So it's really important that we explain to them. And I think what I really encourage my staff to do is not say, I can't do it because it's practice policy, because that gets my back up. People don't know what our policies are. You say, look, unfortunately, I love the word unfortunately, because I think it's nice and soft, hey? Unfortunately, Medicare requires do, and so this is what we can do, or, this is what we can do. Give them options, because options puts the power, it puts the ball back in their court. I can't do this, but I could do this. What would you like to do? So it gives them that sense of control back. And don't avoid the difficult conversations. So I hate confrontation. I'm probably, apart from managing people, I find confrontation really difficult. It makes me really anxious. But delaying telling someone that you can't do something for them is just giving them false hope. And the longer you leave it, the worse the angrier they're going to be. And finally, it's really important to have a growth mindset, reflect and learn. I learn off my staff all the time, and from all the different practices I've worked in, even when I was doing my nursing training, but also my receptionist, I go, I really like the way they did that. I'm going to use that next time. So it's really important to reflect, what did I do well? What could I have done better? And even ask your colleagues, hey, I don't think I really managed that really well. What could I have done better next time? How would you have handled it? And so, have that teamwork approach. So once someone's emotions get out of control, we need to manage it slightly differently. So the first thing we need to do is we need to diffuse the situation. So it's gone on beyond the point where they're able to rationalise and you're able to have that, logical conversation with them. But the first thing we need to do is take control of our own response, because if they're emotional, it's very easy for us to become emotional. And so a couple of things that you can do, and the one that we did right at the beginning is I use it all the time before I pick up that phone or before I call someone into my office and say, hey, do you want to come and chat with me? I actually do take those really deep breaths. And I was talking to one of the psychologists at work, and I was telling her about this one day. She said, oh, yeah, that's what this does. And I teach my patients with anxiety to use that all the time. So it's a really good strategy because if you're in control and calm, that's also going to help them remain calm. Counting to 10, and the other thing is just that positive self-talk to remind yourself that they are angry at a situation. They're not angry at you. It's not a personal thing. They're just angry that they're not getting what they want. They don't understand. So just really take control. Stay professional. Our job is not to be their friend, and it's not to make them happy, and it's not to take sides, to be neutral and just to listen to them. And that is really hard to do sometimes when they're being really disrespectful to you, because we don't deserve that. We don't, we're trying our best, but it's just important to stay as professional as you can. Listen to the person. So as I said, people just want to be heard. And sometimes when people are in that crisis moment or close to it, and their emotions and they're all dysregulated, there's no point talking to them. You just got to let them let it all out. It might take a few minutes, but let them let it all out. I had someone once who I think he was on the phone for 20 minutes, just reeling down the phone at me. And in the end, I waited till he finished, and then I just had this long pause of silence. And he was like, "Oh, are you still there?" I'm like, "Yep, I'm still here." And then he let me talk after that. So you just sometimes they've just got to get it off their chest. Acknowledge and empathise. So empathising with someone is not sympathising, it's not agreeing with them, it's just acknowledging that this situation is making them feel this way. Look, I understand this is really frustrating for you, and I understand you're not getting what you want, and how frustrating that is. Apologise without admitting fault. So often I've had receptionists say, I'm not saying sorry. I'm like, you're not saying sorry personally, you're just saying, I'm really sorry that that's been your experience. The first thing I do when I address a complaint is I'm like, thank you for your feedback, and I'm really sorry that this has been your experience. Often that de-escalates someone straight away. They're like, oh, okay. So just to remember, it's not a personal thing, but you need to do it safely. So a safe apology is doing it without sort of admitting fault. So it's avoiding any potential sort of legal consequences. You just got to be really careful about that. So once they've de-escalated and they've calmed down, you can start refocusing the discussion, and that is like going, okay, so the emotions have calmed down, so let's look at the issues. So let's go back to what you want, what we're trying to achieve, and let's look at what we can do. So what can we do for you and what can't we do? Look, unfortunately, our doctors can't backdate that referral that we went to yesterday. But what we can do is, how many times do we get that? Or, look, you've had the appointment today. We can squeeze you in for a fit-in today, but you have to have it today. Or I can't put you in your favourite doctor today, but I do have such and such available. You can access your records. So is that an option? Would you like to do that? Check your language and tone. So what you're saying, you need to make sure your tone and your body language is matching, because you don't want to give mixed messages. Sure, I can do that for you, and you've got this aggressive stance. Occasionally, I will move a patient to a different location. I don't have the privilege of having an office in my current location, but I will in the new place. So often I'll take a patient into a spare consultation room. Ideally, I should take someone with me. So I always sort of assess, how likely they are to be aggressive. But sometimes patients will play up at the front counter just to get more attention, and taking them to another place gives them the opportunity to back down without being embarrassed. Not everything is going to work every time with every patient, and that's due to a whole range of factors, especially if someone's intoxicated or high on drugs and stuff. So you need to review and adjust as you go along. So adjust your responses to their responses. But again, like we said, it all takes practice and experience. But if you can kind of stick to the principles, it does really help. Finally, there are going to be times where you cannot diffuse the situation. I haven't had this very often, maybe 1 or 2 times, but it's really important that safety of yourselves, your team members, and your patients, your other patients is, the most important thing. So you need to remove yourself and others, and you need to be able to inform the team. So whether that's the duress, the code alarm, or asking someone else to go and tell everyone else. Protect yourself, and that includes not turning your back on someone. And finally, you need to inform the aggressor that you're going to have to call the police, and they will possibly come and remove them. And you never know, that might calm them down, but that one needs to happen sometimes. So finally, as we said at the beginning, this kind of stuff can take a real toll on somebody and the team. So it's really important that you're giving the opportunity to evaluate and to debrief. And I don't think we do that enough in general practice because we're so busy. It's hard to get time together. But it's really important, even if it's one-on-one with a peer or something, that you can vent and make sure you do it in a safe place, and also be mindful that you're protecting the privacy and confidentiality of the aggressor and yourselves and any other patients involved. Make sure you document it. It should be documented on an incident report. I have my incident reports clearly sort of on a clip in my tea room, and my staff know where they are. And because if you don't document it, you can't sort of look at if it's a recurring thing. And then, as a team, you should discuss workplace health and safety and standing agenda on your meeting agenda, so that you can sort of brainstorm together, or like, how can we do things differently? What can we do to make the practice safe? Are we not communicating? How do we manage patient expectations? All those kind of things. And finally, if the incident is really severe, it may be that person or your team needs professional counselling or debriefing. And I have used a professional psychologist before for a team for a serious incident. And certainly your practices should have work cover, and you just get the manager to put a work claim into that, and that sort of covered that. But worst case scenario, like, don't be afraid to use those. That's what you pay your insurance for. Hey. Finally, these are the guidelines, and they're not really guidelines, they're more resources actually. General practice, a safe place. I think that's a 2016 resource, and the new one is preventing and managing patient aggression and violence. So a lot of this stuff is in there, and they have some great template letters at the end and layouts of different rooms. So does anyone have any questions? But I think my team's got better at managing this stuff this year, mainly because we are just getting it on a daily basis, and they've got stronger through it. And I have a meeting with my reception team at least every 3 months. I bring them in for breakfast on a Friday morning, and I roster them on for 3 hours, and we make the doctor start later and supply breakfast, and we do some training or, you know, we have a meeting. And like that is a really hard thing to do in practice, and you have to have a really good boss who lets you do that. But I just think it's really important because otherwise we don't get this training.
How many receptions do you actually have? How big is your how
Yeah, at the moment I've got 6 consultation rooms. We're moving up to 11 consultation. I have 3 receptionists on a day. We had 2, but it just got too busy, especially with COVID last year. And, you know, they were burning out big time. So we have 3, so I sort of stagger them. And then I'm in the background as well. Sometimes I'm nursing, sometimes I'm receptionist. I just do whatever. But yeah, I think a lot of us are understaffed sometimes. And, you know, just like receptioning is a tiring job. I couldn't do it 5 days a week, I can tell you that. Anyway, yeah. Any other questions, thoughts, or tips? Any things you do in your practice?
Oh, look, just you were talking about informing the patient if things are behind, because you can see on BP, you get a good feel.
Yeah,
when
yeah,
you're
exactly.
with those doctors. I find that, especially when they arrive, and let's say they arrive, and you just know, you do, you just
And you know your doctors who run behind too.
Exactly, and it's always best to
Tell
let them know straight away and be honest about it. And I find that sometimes it works to everybody's benefit because that's been raised earlier rather than later.
Yeah.
And you can get them to come back. You may have a free appointment.
Yeah, we've
And
got a
then
coffee shop downstairs,
Yeah.
so we're like, do you want to go and get some coffee? You know?
Yeah, or all those sort of things.
Yeah.
I just think, I find that probably the most useful tool.
Yeah, I always say to my reception, if there's one person waiting and then the next person arrives and they're still waiting, tell them there's one before you. It's still,
And
you've still got one patient going before you.
And then you get those patients, and I had one today that arrives an hour early.
Oh, yeah.
You know, and body's booked.
Yeah.
And
You're like, do you realise you're an hour early, don't you? Oh,
yeah, but I've come, armed and,
yeah.
happy to wait. I think it was just so jolly hot.
Yeah.
The air conditioning at our place was better than
Yeah.
I mean, obviously I was able to let him stay there, but, with all COVID and the limited seating and everything,
Yeah,
that could be
yeah.
an issue too.
Yeah, and
But, I just think just being honest with them
honesty is
and
key.
just let them know where things are at.
Yeah.
And it also gives you another opportunity to have a nice little, it's an exchange of conversation. And I think
I would
it diffuses
encourage,
before it escalates.
Yeah.
Especially if they've got kids too.
Yeah.
We've got a park at the end of where we are. And I'll say to them, look, we're looking at probably 20, maybe 30. So if you want to take the kidlets for a little roam, you went, oh, great idea, boom, and off they go. I mean, otherwise
there's no toys. We don't have any toys
the
anymore.
kids are crawling up the walls.
Yeah,
Right? So,
and
but
that's
you're
that's
right.
a good
Tell them
one.
right from check-in. Yeah.
Gives them the opportunity to make that choice themselves. And
Absolutely.
full decision.
Yeah. And I've even been updating my, before they get through to the actual receptionist, they get a message at the beginning. Please don't ask us about the Pfizer vaccine. If you'd like to book in, you need to do it online. Go to our website, all the answers are there. So many ways you can communicate with people. Well, I think I've pretty much done my time, so thank you.